say a few words about this intercollegiate academic postgraduate program, which is also well known as IAPP. This was started more than a decade ago by the heads of the departments of community medicine of the medical colleges of Dakshin Kannada district. One of them is Dr. A.G. Kulkarni, who is currently the president elect of IAPSM. So I'm sure all of you must be aware of this and familiar with sir as well. So this particular forum was then started with the objective of enhancing or providing a platform and opportunity for the postgraduates of the community medicine department to gain more knowledge and skills. And the way it was conducted was, it was on a rotation basis, on a monthly basis. Academic activity like a CME or any other training workshop was being conducted by the community medicine departments in all the medical colleges on a rotation basis. And this gave a platform for the postgraduates also to interact with each other, know each other, and get to know what more can be done with respect to the competencies or the skills that all the postgraduates are having in the different medical colleges. So this was a very useful opportunity for all the postgraduates then. However, with COVID, this took a backseat, and we were not able to, for some time, we were not able to continue with this IPP activity. But now, after the COVID, we have again restarted this, and with a new form of trying to reach out to a larger audience. So, I restricted only to the postgraduates of Dakshin Kannada, we thought why not reach out to all the postgraduates from the other parts of the country as well, because COVID has the one of the major advantages that we got from COVID was the online platform, and with this we are able to conduct uh, sessions and reach out to a larger audience as well, and thereby this IAPP is now being conducted on a national level so that all the postgraduates are able to get the best out of it. And for this and today's session, it's a pleasure to have with us Dr. Manish Singh, Associate Professor from Department of Community Medicine, Dr. RMLIMS, Lucknow, Uttar Pradesh, with the topic on recent updates, PEP, and management of rabid animal bite. It's a privilege to have you over here, Dr. Manish Kumar Singh.
Yeah,
I
thank you.
welcome you.
Thank you so much, ma'am. Thank you to sir as well for this opportunity. And I'm eagerly looking forward to the interaction with the participants.
Yeah, thank you for accepting our invite. Uh, Dr. Kulkarni sir is also with us. Sir, you would like to say a few words?
Yeah, you have already briefed about IAPP. It's wonderful to see Manish accepting our invitation. And rather than I speaking, I would like to listen to Manish. Over to you, Manish.
Thank you so
Yeah.
much.
So, as we all know, rabies is fatal, but yet it's preventable, and it is also being included in the WHO's 2021 to 2030 roadmap for global control of neglected tropical diseases. And more towards with respect to its updates and management, we will hear more from Dr. Manish. Dr. Manish, over to you. Thank you.
So thank you, ma'am. And once again, I thank all the organizers for giving me this opportunity. It's a very important topic, a very important neglected tropical disease, I would say, which is 100% fatal, but at the same time preventable. So, and we need to work ahead to uh, prevent the deaths due to dog-mediated rabies in humans. So I'm just sharing my slides. So the slides are visible, ma'am.
Yes, the presentation is visible.
Okay. So to start with, now in today's lecture, we are going to talk about what are the recent changes in the pre-exposure prophylaxis and what are the recent guidelines with respect to management of a rabid animal bite. So to start with, as you know about rabies, it's one of the oldest known diseases to mankind, and it's 100% fatal disease. That's why it's very important, so that it's recognized timely and we take the preventive measures on time so that the death can be prevented. So interestingly, the word rabies is derived from a Sanskrit word that means rabhas, and that is to do violence. And this disease even finds a mention in the oldest uh, Indian text, that is Atharva Veda, where it is shown that Yamraj is being accompanied with two dogs who are the emissary of death. So, it also has a mention in the Susrat Samhita where the different manifestations have been mentioned. So, there are many historical accounts which show that this is one of the oldest known diseases. It's caused by a virus that belongs to a family of Rhabdoviridae. Uh, Coming to the problem statement, if we see, so globally, if we see every 9 minutes, someone is dying from rabies globally. So it is present in over 150 countries across the globe, and all continents are affected except for the Antarctica. It is estimated to cause around 59,000 human deaths annually, but this figure is quite underreported. The actual numbers may be even higher than this. And if we see about the distribution of these deaths, so we'll find that Asia reports about 60% of these deaths, and Africa is responsible for the another 36%. So together they are contributing around 95% of the human deaths. And if we talk about India, then the figures which suggest that there are around 20,000 deaths. That this is again some underreporting here. The actual number of deaths might be even higher. The reasons being many of the rabies deaths are not reported because it's a fatal disease. When I was doing my MBBS in SCB Medical College, Cuttack, I tried to find out, and there was not a single death reported at the institute. Although we had a rabies clinic and many patients used to come in, because the people try that they know that since it's fatal, let's take the patient home. That will take him home, and he dies. So it's not reported first of all. And many a times the diagnosis is also a bit complicated, especially for there are two forms of rabies, as you know. One is furious, and the other one is paralytic. So for the second one, it's often misdiagnosed. So this is the figure that shows that around 20,000 deaths India has, and this through modeling studies also we have come to a conclusion that there are 20 to 23,000 deaths that are reported annually in India, and nearly 1.7 crore animal bites occur every year. So this, if we compare with the global figure, India accounts for at least one third of the global burden, and 65% of the human rabies deaths in Southeast Asian region, which is quite a high number. So with the target of having zero human dog-mediated human death due to dog-mediated rabies by 2030, it's very essential that we, as a country, move towards the elimination of rabies in a fast manner. Most of the victims of these dog bites are children who are under 15 years of age. The reason being that children usually play with dogs, and the incidence of dog bite in children is often ignored, or it is not reported because they take it lightly and do not report to the parents. So it's often missed. So this is one of the reasons why the this fatality is also even higher in these children. So this is I took a slide from the National Action Plan for Rabies Elimination, and this is the clinically suspected human rabies cases and deaths since 2012 to 2020. So as you can see, there are three states: Maharashtra, there is West Bengal, and Bihar, which are showing a very high suspected human rabies cases as well as death. But at the same time, there are states like Uttar Pradesh, Rajasthan, which are showing zero cases and zero deaths. So that shows that there is a gross underreporting still happening, and which has to be worked upon. And the reporting should be correct so that the preventive measures could be planned accordingly. Now, coming to the global economic burden, if you see, then it involves treatment cost and other costs. So if you see, around 8.6 billion US dollar is being spent every year on rabies, and out of this, 37% of the cost is treatment cost. So around 318 crores. So that involves the travel, the direct cost of the vaccines and all, and the loss to income because of seeking treatment. Other losses are like death due to premature death, and the because of dog vaccination, and livestock losses that we suffer. So, route of transmission, as you know, it's basically the most common is a transdermal bite and scratch by an infected animal. Direct in contact with the infectious material like saliva with the victim's mucosa, and fresh skin lesions can also result in the transmission. Rarely by inhalation, it's mostly in case of bats. And human to human transmission not been reported, not been confirmed. Theoretically, it's possible, but and last is the ingestion. So again, theoretically possible, but not reported. So which animals transmit rabies? This is very important to know because when we are going for the management of rabies, we must be aware which are the animals which are likely to transmit rabies and which are not likely to transmit. So this is the list. Dog and cats, they actually comprise 97% of the rabies that is transmitted is because of the domestic dogs and cats. The remaining 2% is from wild animals such as monkeys, mongoose, foxes, jackals, and some due to peridomestic animals like cows, buffalo, sheep, goat, pig, donkeys. It's not reported in rodents, neither in birds and bats. Recently in Sri Lanka, there were a few deaths of squirrels, and when they investigated, they found the rabies virus, but still not reported in India. Coming to the incubation period, again, it's highly variable. It can vary from 3 weeks to 3 months, and it may vary from an average, say, 4 days also to 2 years. So average is 3 week to 3 month. So and the period incubation period is shorter in case the bite is on the head, on the face, or say in the upper limbs, compared to when the bite is in the lower limbs. So now coming to the presentation, there are two type of presentations that I already discussed with you. One is the furious form, and the other one is the paralytic form. So most common is the furious form, and this manifests mainly as hyperactivity. The patient will present as anxiety, agitation, having a bizarre behavior, and it may be spontaneous, this hyperactivity, or it may be precipitated by some auditory or visual stimulus. So other characteristic symptoms are hydrophobia. That is the moment the patient even hears the sound of water or is face to water, the pharyngeal muscles contract, is unable to take water. And aerophobia, the facial muscles will have a spasm even if there is a movement of gush of air coming in. So this is a very painful death which happens. The other form is the dumb rabies or paralytic rabies. This is often confused in the diagnosis because it's mixed with some other conditions as well, because it presents with flaccid paralysis, so often misdiagnosed and not reported. So incubation period will be shorter if the bites are on the face, neck, if there are multiple bites, or if the bites on the fingers and genitals. It's usually seen that if no PEP is taken, then in case of 55% will get, if the chances are higher, up to 55% if the bites are on the upper side, upper face, abdomen, thorax, like that. So what are the strategies now? Strategies, there are two strategies basically if you want to prevent rabies. And one is the dog vaccination, that is to interrupt the transmission to humans. So that's the animal component. And the second one is the human component. So we are going to discuss about the human component and we'll briefly discuss about the animal component as well. So coming to the human component, we have two important things here. One is called the post-exposure prophylaxis and one is the pre-exposure prophylaxis. So coming to the post-exposure prophylaxis, now this disease is endemic in India and is very common among sustained by dog-to-dog transmission. So, and any kind of a dog bite, all suspect animal bites are potentially, we suspect that it could result in a rabies. And the management further depends on the categorization of the wound. So the first thing which we have to do in post-exposure prophylaxis is washing the wound. So the immediately as soon as there is a bite, it should go the awareness. We should bring in awareness that it should be the wound should be washed under running tap water for at least 15 minutes, and we should use some kind of a soap that creates lather because this virus has got a upper coating, fatty coating. So the moment you use soap, it gets destroyed. So this is the most important measure that we must take. And even if the whatever patient reports to your clinic, even if he is coming late, this procedure must be followed. The wound washing must be done. Secondly, once we are done with this, then we go for the this is a local wound treatment. Again, what we see. So mechanical is under running water. Chemical, we use some soap. We can use disinfectants as well. Suturing should be avoided. In case it is very much required, we have to give loose sutures, but that has to be after the implementation of the immunoglobulin. So we'll discuss when to give immunoglobulin in which cases. Then these are the don'ts that we do not need to apply any of these irritants. We should avoid cauterization. We should not touch the wound with bare hands. Now coming to the categorization of the exposure. So this is the category 1, 2, and 3. This is very important in case of management of rabies. So one is just the licks on unbroken skin, touching and feeding of animals. So nothing is recommended other than you should just wash off this properly. So category 2 and 3 is where we need to intervene at a priority. The category 2 is like scratches, but there is no oozing of blood. And category 3 is this is licks on broken skin, or there are single or multiple transdermal bites and there is bleeding. So one of the tests which we do is a spirit test. So if you just move a spirit and you can feel the sensation, that means it's a category 3 bite. You should go ahead with the administration of immunoglobulins. Now, this is the decision to treat. So in category 2, we recommend the anti-rabies vaccines. And in category 3, along with the vaccines and wound management, we also recommend the rabies immunoglobulin or monoclonal antibodies. So if you see these exposures, these are all category 3 exposures. You can see these are on the face, there are multiple wounds. There's very obvious bleeding that you can see here. So all these are category 3 bites. So now coming to the administering the anti-rabies vaccine, again there are two routes, intramuscular and intradermal. So in all government health facilities and under the National Rabies Control Program, we are promoting the intradermal vaccination. So it has many advantages. First of all, it's a cost-effective compared to the intramuscular because we can actually administer many more doses in compared to the single dose that we administer in the intramuscular. So even less number of visits are required here, and it's a very much viable alternative to intramuscular route in India. And if we talk about the efficacy and with compared to the intramuscular route, it's even equally efficacious and equally effective compared to the intramuscular route. So this has been notified by the DGCI for use in India, and it's promoted under the government program. So this is the schedule that is called as the updated Thai Red Cross regimen, and we give it on two sites. So what you see here is 22202. So two means and it is to be given on. So day zero we give on two sites. Then on the third day we again give on two sites. Seventh day we again give on two sites. We forego the 14th day, and then on 20th day we again give the two on two sites. So day zero is actually the date of administration of the first dose of the vaccine, and it will take zero point 0.1 ml at each site. So zero point 0.2 ml is the total administered dose on each day, and usually given over the upper arm of each deltoid and anterolateral aspect of the thigh. So now the WHO has further refined this regimen, and as per the WHO strategic advisory group on immunization, they say that now you can just with this Thai Red Cross regimen, you can go for 222. There's no requirement for the last two doses that we are giving on 20th day. But this has not been approved yet by the government of India. So in our country, we are going with this 22202. So this is the correct technique of ID injection. In case gets the vaccine goes to subcutaneous or it's just spills off, then we need to administer it again. And some immunosuppressed we give prefer to giving, or those who are using chloroquine will prefer to use the IM route. Now coming to the IM route, so this is the SN regimen that we follow in India. There is another regimen called Zagreb regimen, but we follow the SN regimen. So five doses is administered in this. That is on 0, 3, 7, 14, and 28. And the day zero is again the date of administration. The dose is 1 ml, the entire vial we have to give. And again, intramuscular and deltoid or anterolateral aspect of the thigh. This regimen again has been shortened by WHO, which says that instead of the 5 visits, we can have it 4 visits. So they say 0, 3, 7. We can avoid the 14th day dose, and we can give the fourth dose between 21 to 28 days. But again, still not approved by the government of India. So we are going with the 5 dose regimen in India. So these are the different companies, different brands of rabies vaccines that are available in India. The precautions is we have to follow all the aseptic measures that we take in any injection that we give. We have to store at 2 to 8 degrees Celsius and reconstitute it since the vaccine is so it has to be used within that particular session, and all unused vaccine has to be discarded. So coming to sometimes there are some practical problems may happen that the patient may complain that the vaccine that was given initially that is no more available in the market. So is it recommended that we can change the brand of the vaccine? So usually it's not recommended. It's said that you should follow the entire course of the same brand. But in case it is not feasible and under any circumstances, then yes, we can change it. Also, with regards to the change of the this route of administration. So, suppose somebody is taking an intramuscular regimen, so it's not recommended that you change the route of administration. But in case there are certain circumstances which require to change the route, then we can change the route. Then and we follow the schedule of the route that we are changing to. Suppose we are starting with intramuscular and then we change to intradermal. So we will follow the schedule of the intradermal. After that, whatever dose that the person has received for intramuscular, that's fine. The subsequent doses has to be as per the schedule of the intradermal if they are changing from IM to ID. Now, coming to the administration of immunoglobulin, this is very important because once we administer a vaccine, it takes some time to build up an antibody response. So, in case of rabies, it will take around 14 days to build up an antibody response in the body. So, for that, in case of category 3 bite, which could be very fatal because it's close to the brain and has a very shorter incubation period, we need to administer immunoglobulins. So once we have washed the wound, it removes most of the viruses. Then we go for the immunoglobulin. So it neutralizes the remaining viruses and reduces the chance of progression to rabies to a great extent. So we have the equine rabies immunoglobulin. We have the human rabies immunoglobulin. So this is the dose, 40 international unit per kg body weight. And for equine and for human, it is 20 international per kg body weight. So we can calculate the dose as per the body weight, and then we need to infiltrate this immunoglobulin into the wound. So we infiltrate as much as is anatomically feasible, and the remaining dose. Earlier, it was recommended that we give it intramuscular, but nowadays we do not recommend. It's not recommended to give the remaining as intramuscular. So whatever is feasible, we give it in the wound itself. So we start with piercing into the wound, and then as we withdraw the needle through the wound, we just push a bit of so that the immunoglobulin gets distributed. It should ooze out of the wound. So that's the technique that we follow. So this is the pathogenesis why we are giving immunoglobulin because the virus is actually neutrophilic. It attaches to the peripheral nerve endings. So once we wash it, we remove a lot of virus. Then the remaining virus has to be neutralized using the immunoglobulin. And this is the why we are using immunoglobulin because to build a safe antibody response, it will take around 14 days if the person has not been vaccinated earlier. So, if we give ready-made immunoglobulins, it neutralizes the virus by that time. It takes care of the this unsafe period that is there first 14 days. So, these are some notes, important notes regarding the administration of immunoglobulin that has to be brought to the room temperature before instilling. Only that much which is anatomically feasible should be given. In case it is insufficient in volume, which we calculated as per the body weight, then we can dilute it with the sterile normal saline up to equal volume. And in case the patient has previously received a complete course of post-exposure prophylaxis or he has received a pre-exposure prophylaxis, then it's not recommended to give this immunoglobulin in that case. And these immunoglobulins are very safe. There is very less chance of any kind of a reaction, but still we should be having the precautionary measures ready. We should have we should keep an adrenaline with us in case there is an anaphylactic shock, which is extremely rare. We can manage it. So medical advice what we give to the person who has received the vaccine There are no such dietary restrictions. We counsel him because the person is very much emotionally and might be under physical stress as well, specifically mainly the children who are there. There is no restriction on physical exercise, but we avoid immunosuppressants, steroids, antimalarials if possible, avoid the consumption of alcohol, and we advise for a complete course of vaccination. Now, there is another question is that like suppose we have pets in our house and or there are pets with the neighbors, and if the pet dog bites us, should we go for the vaccination? So the answer is yes. Even in case of pets, if it's a pet, we should go for the complete course of vaccination because even if the person says that the pet has received all the vaccines, we the actually the immune response in the dog in a country like India, which is endemic, depends on many things like what was the health condition of the dog, who administered that vaccine, the skill of that person, how much dose was given, what potency was that of the vaccine. So we cannot take such risks. In case in Western countries where we have the facility of measuring the antibody titer, so in that case, like if our country doesn't have such well-supported labs so that we can measure the antibody titer in the dogs. So it's better to take the complete course of vaccines. And secondly, those who are keeping pets, particularly the children, are likely to be exposed to the animal bite. And that is often missed or not reported by the children out of fear, or they do not take it that seriously. So I have seen kids in my place where there was a kid who was trying to put in the biscuit, feeding the biscuit to the dog, and the dog was refusing. So just open the mouth and push the biscuit inside the mouth. So these kind of things, or dog just they hold catch hold of the tail of the dog, so they can bite in the response. So for such cases, it is advisable. Now, IAP also recommends that we should go for pre-exposure prophylaxis in children. So the advantage is again, it will reduce the number of doses of subsequent doses of vaccine. For if we give a pre-exposure prophylaxis today, so it will subsequently reduce the need for immunoglobulin first of all, and the number of doses, booster doses, whatever will be required, is also reduced. So then we is observing the animal. Suppose it's our own pet and we say that we have vaccinated it completely. So in dogs and cats only, we can recommend, if it's a pet, we can recommend that you observe the dog for the 10 days. And if there is no change in the behavior of the dog, then you can convert the post-exposure prophylaxis into a pre-exposure one. So you have given 037. So 14 you can avoid, just give the 21 to 28, you can take another dose and it will be converted to a pre-exposure. So then coming to a re-exposure, suppose somebody is there who says that they had a previous exposure to dog bite and they have taken a complete course of the vaccine. So here also wound toilet should be done always. Whoever reports with an exposure to dog bite should be given a proper wound toilet of 15 minutes under tap water. RIG is not recommended here because the patient already has a memory of previous exposure and they can build up antibodies quickly. So no RIG is recommended. And what we recommend here is a two booster dose. This re-exposure, if it happens for within the 3 month of giving the complete course, then nothing is to be done. But after the 3 months, we require to give at least two booster doses. So they can be given both IM as well as ID. So that will be on 0 day and third day. And this for ID, since we know that it is given on two sites, but here it is recommended only on one site. So all incomplete and partial vaccinations, if they are reported, then they should be treated as a fresh case and it should be managed as a fresh exposure to dog bite. And in case there is a history of somebody having received the nervous tissue vaccine, which was used earlier, so in that case also, if there is a re-exposure, then we go for the complete course of vaccination because these days the vaccine that is available are either varicella vaccines or chikungunya vaccines. Nervous tissue vaccine is no more used. So that used to be given when I was an intern. So I have given those nervous tissue vaccine, but now they are totally discontinued. Now, this is the latest development, that is a monoclonal antibody. So this is a recombinant, using of the recombinant DNA technology. We have actually gathered the antibody. These are IgG antibodies, And two brands are currently available in India. One is the Rabishield and the other one is the Twin Rab. So, Shield is basically a single IgG1 monoclonal antibody, and this is the dose that is 3.33 international unit per kg body weight. It's safer compared to the human immunoglobulin, equally efficacious. And the best part is that there are certain issues with the availability of human immunoglobulin. But since this is made through a recombinant DNA technology, so these monoclonal antibodies are quite easily available. Because still there is a problem in UP. If I see there are places like Gorakhpur, they do not get the immunoglobulin. So we have to come to Lucknow. So that could be an issue of availability of human immunoglobulin in the peripheral areas. So in that case, this monoclonal antibody has a wider reach, wider production can happen. So this is the Revishil 3.33 international per kg body weight, and it comes under in 2.5 ml vials. So it can have 100 international unit or 250 international. So you need to calculate the dose. Whatever is anatomically feasible, we infiltrate in the room. The remaining we discard off. And this is the second brand that is available, that is Twin Wrap. This is basically a cocktail of two different IgG antibodies that bind to two different glycoproteins on the rabies virus. And this is again available in a sterile liquid form for injection, ready to inject in different vial sizes. So as per the dose that is required in the particular person, we can choose the vial and give it. Now coming to the pre-exposure prophylaxis. So pre-exposure prophylaxis is not recommended for everyone, but there are specific groups that we'll discuss in the subsequent slides whom we actually recommend to go for pre-exposure prophylaxis. So again, there are two ways, either to give it intramuscular or intradermal. In both the cases, we give for 0, 7, and the third dose at 21 to 28 days. So three doses are recommended in India. WHO has actually cut short this even further, and they say the sage recommendation is to give only two doses, that is 0 and 7. So there is no need for going for 21 or 28 days dose. So, but still, there is not official guideline from our country in our country. So we still follow this 0, 7, and the third at 21 or 28 days. So, and another change that is there from the WHO regimen is that in intradermal, we are recommending only zero point 0.1 ml at single site, whereas WHO says it's zero point 0.1 ml on two sites. So this is the difference between Indian recommendations and the WHO one. Now, these are the people in whom it is actually recommended. Those who are at the high or continuous risk of exposure, like say their lab personals who are either they can be on the rabies research lab, or those who are working on the diagnostic labs, they're veterinarians or they're animal control people who are involved in the animal birth control measures, or wildlife officers. So these people, it is recommended to have a pre-exposure prophylaxis. Secondly, for travelers who are traveling from a rabies-free country to a rabies endemic area, and their activity, what they are going to do, suppose they're photographers or some kind, whatever the activity they plan is likely to get, they're getting likely to be exposed to a rabies animal. So that way they have to be protected from rabies. And now it is being recommended for children. Again, there is a recent development. This is a new vaccine that has come up, TH rabies, by the Candila Pharmaceutical. This is a recombinant nanoparticle-based G protein vaccine, and this vaccine is a further improvement over the previous vaccines, that 5 doses that we're giving. Here, only 3 doses of vaccine is recommended over 1 week. So it has been recently approved by the DGCI, and this is actually launched in 11 states. So this is the new development that has taken place. Something about the 0 by 30 initiative, that is zero human deaths from dog-mediated rabies. So this is the, as we move from left to right, this is the response that we are aiming at. So from an endemic country to controlling phase, that is we bring down the incidence of rabies death to a condition where there are zero human death due to rabies, and then there is elimination, that is for a continuous period of 24 months. There is not a single case of human death reported, and to a rabies-free status, that is there is no transmission in dog, as well as there is no confirmed human rabies case. The India has is equally committed to this initiative, and we have recently brought about this new National Action Plan for Rabies Elimination, which has two components. One is the human health component, which is basically to ensure that everyone who has an exposure to a rabid animal has a timely access to post-exposure prophylaxis, and to create a responsive public health system that seriously takes it seriously and effectively, and ensures the complete course of vaccination to the exposed person. At the same time, awareness in the community about the initial management, immediate treatment, and the animal component that seeks to achieve 70% of rabies vaccination in dogs in any defined geographical area for annually for 3 consecutive years. Along with this, there is a focus on animal birth control measures as well. So this is what we are planning under the National Action Plan. So there is a rabies control program in place now, and it's which started as actually as a pilot in the 11th five-year plan from 2007 to 12, and then in the 12th five-year plan we actually formulated this national rabies control program. So it focuses on these seven things. So this number one is the advocacy about a regular uninterrupted supply of anti-rabies vaccine, establishment of model rabies clinics at district level, training of any on animal bite management, prevention, control of rabies, on surveillance and intersectoral coordination, which is very important because rabies is a one health, it requires a one health approach for if we are moving towards elimination. Multiple sectors are actually involved in the management of rabies. Now, strengthening the surveillance, that is again building up on our lab networks and reporting of the rabies animal bites as well as rabies deaths, creating awareness about rabies, strengthening the intersectoral coordinations, and support states under NHM for state and district level operationalization of this program. So this is what is there in my talk today. So now, if there are any questions, I'd be happy to take up the questions.
Yeah, thank you, Dr. Manish. So that was a very comprehensive session delivered by you, focusing on all the updates as well as the national action plan strategies. I'm sure this would have been of great help for all the postgraduates and other participants who have logged in for our session. So, participants, if they have any questions, either they can unmute and ask, or even if you have any comments, or you can post it in the chat box. So the questions will be addressed. Rishma, you may please post the feedback link also in the chat box. And for
Yes, ma'am.
participants, on filling the feedback form, auto-generated certificate will be delivered to the email ID that you would have mentioned in the feedback form link. So there are certain comments like it was a very informative session and a very useful one.
I think there's one question also, ma'am. Somebody wants to. Subhashri has raised her hand.
Okay, just check. Okay, so those who have raised hand, you may kindly unmute and ask. First. Those who had raised the hand, I think maybe that was my mistake, I believe, because
Okay. One more thing,
No,
like yeah, sir wants to speak, sir.
they are thumbs up. This is not raising hand. They're thumbs up. That means it's a
No, no,
wonderful talk. That's what they're saying. Yeah.
thank you, sir. One more thing, like there's a question that often comes to us, like till how long we can give the immunoglobulin? Because if it's a category 3 bite, and there is an issue with the availability of an immunoglobulin. So we should immediately start with the vaccine. If it's a category 3 or wound, then we start with the wound, we do the wound management, we start with the vaccine. It can be given till the third dose that we give on the seventh day, but not after that, because if we give after the seventh day, it will interfere with the immune response. So if we have these 7 days in our hand to ensure the availability of the immunoglobulin. So there's nothing to panic. If we can arrange it within the 7 days, we can give the immunoglobulin still. So that's one thing I think I had missed in my slides. So, and one more thing is there, like when we go for a pre-exposure prophylaxis. So suppose there's a family of five, or even in case of, say, there is a post-exposure in case of a child. So there is one advantage of giving intradermal vaccine. So suppose there is a one vial, we can have only 0.2 ml is required for intradermal. So you can give it to the person who is exposed. The remaining amount we can use for the pre-exposure prophylaxis in the other members of that family. It will be cost effective, and they will be if there is subsequent anytime there is a post exposure, so they will not require the immunoglobulin. So that is the another advantage and of even private practitioners going for intradermal route.
Okay, so if there are no questions, yeah. Vinod,
Sir,
any? Yes, yes, please.
sir, myself,
Yeah.
Abhinav from.
Yeah, Abhinav.
Sir, there's a lot of confusion. Sometime many of people says that his dog has already been vaccinated and the person doesn't need vaccine. So what we should do? Because I joined the session late, so I just wanted to clarify that.
Okay, so even if the dog is completely vaccinated, in a country like India where rabies is endemic, we should go with the complete course of vaccination. That is
Okay, sir.
recommended, because we are not sure, like how is the because the human immunoglobulin or vaccines, their quality check is done. We're not sure about what is the quality, what is the potency of the vaccine that was given. Secondly, who gave that vaccine, whether it was given in the correct manner or not, or the correct dose was administered. So there are some doubts. In Western countries, they have very good labs. So if such a case happens, they can go for the antibody titer of the dog, and they can see if the dog has a protective antibody titer, then they can avoid the vaccines. But in India, even if it's a pet dog, it's a scratch also, we should go for the complete course of vaccines.
Okay. Thank you so much, sir.
Yes, Vinod
Vinod
speaking.
Singh.
Sir, good afternoon. Sir, if
Yeah,
in
good
a
afternoon.
condition we have not any immunoglobulin, then
Hmm. So if you don't have an immunoglobulin, I said no, there you have 7 days still to arrange an immuno, because immunoglobulin is very important for category 3 bite. There have been incidences that I have a book also on rabies which I have authored, and the importance is highlighted by the fact that there was a newspaper uh, report which said that there was a class 10th boy who was bitten by a dog and he received the complete course of vaccination, but still the patient died. The reason being that immunoglobulin was ignored. So immunoglobulin is actually very much required, because it's in category 3 bites. So you have the time, you have the 7 days till the seventh day of giving the third dose of vaccine. We can arrange for the immunoglobulins. Monoclonal antibody, that is the recent development, is actually an advantage because its availability is more compared to the human immunoglobulin. So it should be given that way. And that's why we are also emphasizing on the pre-exposure prophylaxis in children who are more likely to be bitten. Or in case your occupation is such that you are like, even we go to the field sometimes to villages for field studies. So you never know, you can we have an exposure. So better you take a pre-exposure prophylaxis. I was a surveillance medical officer in WHO earlier, and there was one of my colleagues who was chased by a dog when he was going for a field visit, and fortunately he somehow escaped, managed to avoid the dog bite. But then going to field visits for polio surveillance or for any other purpose, there are instances when it could could lead to the exposure. So better to have a pre-exposure prophylaxis. And in veterinary colleges, they all the first students, like we go for hepatitis vaccination in medical colleges. In veterinary colleges, all the students are actually done with pre-exposure prophylaxis.
Sir, last one. Sir, double dose of ARV can be administered if any condition immunoglobulin don't.
I didn't get your question properly. Double dose means?
सर इफ एनी कंडीशन इन रूरल एरिया आप
Hmm.
मैनेज नहीं कर पा रहे कि इम्यूनोग्लोबिन नहीं है क्या अपन
Hmm.
उनको डबल डोज ऑफ एआरवी लगा के मैनेज जैसा
You see, both
कंडीशन
have different mechanism. The vaccine that you are giving today will take some time to build up an immune response. And the wound management and the other thing, immunoglobulin that you are giving is actually neutralizing the virus at that particular point of time. So the moment you wash the wound, 95% of the virus is gone. 99% you can say. The remaining chances of having 1 to 2% of the virus, that has to be neutralized through a immunoglobulin. So, both are important. The immunoglobulin is particularly important in category 3. We
थैंक यू सर
cannot give the double dose of vaccine for that.
Dr. Manish, there are two more questions. I
Yes.
think the first one is answered. I'll just still read out. Reasons or chances of deaths even after administering rabies immunoglobulin on time.
There are not, do you see, if you administer the entire schedule on time and you have given immunoglobulin, the chances are negligible. And it's very unlikely that it could be due to the death is due to rabies. But still, there can be reasons if the potency of the vaccine is very important. So, what we say is that the potency should be, say, 2.5 is the units of that measurement of potency. So, that potency has to be there. The vaccine has been stored properly in the cold chain and all. So that is one. Secondly, is the administering technique. The person who is administering, if say we are going for intradermal vaccination, so the staff has to be trained in intradermal. So if the vaccine goes in subcutaneously or it spills out, then it's a risk because the vaccine is not properly given. So that is the thing. So the we have to take care of the potency of the vaccine, ensure the vaccine we take the vaccination from the correct place, from the right, and the secondly, the person who is administering. Usually, it's not very difficult to give an intradermal. So most of the health staff is very well trained to give intradermal vaccine, so that won't be an issue. It usually does not happen if you take the entire course.
Yeah. So the next question is category 3 bite within 3 months of giving complete vaccination and immunoglobulin.
So 3 months is actually like a prepaid SIM card. So if you have taken a complete course of vaccine and for that 3 months, if there is another subsequent exposure, nothing else is required. But you're protected only for those 3 months. If it crosses the third month and if it's in the fourth month, the exposure is there, then you have to treat it as a re-exposure. So you need to take the booster dose. So if you have taken the complete course, then you can like go ahead and offer also like if there's a bite, no issues. For the first 3 months, you are protected with that.
Yeah, so there's one more question. If a patient has been vaccinated with rabies immunoglobulin and vaccine just a month back and is coming to OPD with the history of dog bite, should we give the vaccine again? And
So
what would be the schedule?
yeah, that's the same thing which we answered before. That if he has taken the complete course and he has taken immunoglobulin as well, for the first 3 months he does not require anything. If there's a subsequent exposure within that 3 months, but after that, you immunoglobulin will not be required anymore because you're already given immunoglobulin once. So antibodies course is given, so the body has a memory cells that they can regenerate the antibody response very quickly. So only booster is required. That is 0 and 3, 2 doses are required. History of consumption of milk from cow. This is not reported in India. So there's earlier it used to be written in park that if you take milk from a cow who is infected of rabies, you are likely to get rabies. But no, it's not a possibility anymore. So it's not exposure counted as an exposure. And even some places they also eat dog meat. So although not recommended, to eat dog meat, but since these viruses are very heat labile, and the practices in India is for whatever animal food we eat, we used to boil it or we used to cook it at a very high temperature, so unlikely to be transmitted through that particular.
So it was, I think your session was really very interesting and stimulating for the participants. And that is why so many participants have come up
Good,
with more of
that's good,
questions,
man.
and they are inquisitive to know more. That was good. Good participation
This is
from all.
something like rabies we must take up in community medicine, because even in our college, even if somebody is a surgeon or even if it's a medicine specialist, they still consult us. What should we do? So at least we are considered an expert in rabies. So
This field.
this is one field we must actually work upon, and we can set up model rabies clinics in our departments. So this is a very great field where we can work upon many. And now since the government is working on the rabies control program, so that's an added initiative where we can contribute as a epidemiologist, mapping the cases and bringing up the what is the like where the cases are being reported. So that way we can help.
Right. Yeah.
Thank you,
Thank
Manish. It was very nice to listen to your crisp and informative talk. Really good. Thank you.
Thank you, sir. Thank you so much.
Okay. So we conclude the session. So for the participants, the feedback link form link will be open for another 10 minutes. If anybody has not filled, you may kindly fill the form. After that, it would be the form link would be closed. Thank you, Dr. Manish. Thank you
Thank
for
you,
the
ma'am.
excellent session and accepting our invite. Thank you very much. Thank you,
Thank you so
Kulkarni
much.
sir, for being with us.
Thank you.
Thank you all.
Thank you all. Thank you. Thank you.
Thank you,
Thank you all.
everyone.
See you. Have a great day.